Hi, and welcome to Relapse Prevention, brought to you by lceus.com. Relapse prevention is one of my favorite topics because when we talk about relapse prevention, it's something that people can start doing at the assessment. It's not something they have to wait until the end. Actually, it's preferable if they don't wait till the end. And it gets patients thinking about practical things that they can do in order to help propel themselves to where they want to be. So we're going to look at defining the strategies that we can use in the different stages of readiness for change. We're going to identify the most common relapse traps, discuss the purpose and procedure for relapse prevention planning, and identify ways to individualize relapse prevention plans based on people's temperament and learning style. So, stages of readiness for change. We've all been through these before. If you've watched many of our videos, you've probably been through this, so we're going to keep it brief. But basically, pre-contemplation, the client doesn't really believe that he or she has a problem. So what we can do is establish rapport because they're probably there under some sort of duress. Make them feel at ease, help them understand that we're not going to make them do anything. We may have to abide by certain rules if we know that they're court-ordered to 12 sessions of counseling, but we're not going to pathologize them, we're not going to do anything invasive, and it's going to be okay. We want to raise doubts about their pattern of use, so we want to talk to them about how much are you using, how often, and normalize it or compare it to norms, and if it's not normal, show them that, 24 beers on a Sunday is not what the average person generally does. But just putting the information out there, not using it as an accusatory manner or saying, well, you're wrong, you're an addict. That's the fastest way to get somebody to shut down. We want to form an alliance and help the patient sort of form an idea on their own about exactly where they are. And we want to give information on the risks and pros and cons of use. There are benefits. And if we fail to identify those benefits, then the client feels like they're being snookered a little bit. Think about if you went to a place to buy a car and the car salesman told you all the great things about the car and said, oh, there's no drawbacks. This is the perfect car. No car is the perfect car. There are different little things, and a good salesman will say, well, we've got to prioritize what you want. And so if you want something with more leg room in the back, this car doesn't have as much, but this one does. Then you feel like he's being more honest because he's saying, okay, this may not have all the things that you're looking for. So we want to give information on the pros and cons, but we don't want to make it a lecture. Let them know, I'm concerned about your use because you're telling me you're using opiates and you've been using them for about 6 months now, and you're still experiencing chronic pain. So let's talk about what opiates do to our natural endorphins and the fact that as your body becomes dependent on them, it quits producing those natural painkillers. So yeah, you are going to feel more pain when you're not taking the opiates as much until your body kicks in and starts making those endorphins again. So you can have a conversation, educate the patient, but again, in pre-contemplation, you really want to steer as clear as you can of sounding like you're lecturing, accusing, or labeling. Patients in contemplation are starting to see that they might be doing it a little too much, or they might have a little problem, but they think they've got it under control. They don't need anybody else's help. That's fine. So, might as well use the counselor as a sounding board. If you're there, might as well use them. So discuss and weigh the pros and cons of using. Again, pros of using, we got to address them. Drawbacks to using, they've heard them all before, they don't really care. So what does that mean? That means the benefits to using outweigh the drawbacks. That's interesting. So we need to tip the balance on that scale. Not yet, though. We want to emphasize the client's free choice and responsibility. Put the decision squarely on the shoulders of the client. Think about the last time somebody forced you to do something. You have to do this. Well, you may have done it for a little while, but then you started doing what you darn well pleased. Same thing with change. If the client feels forced into it, they're less likely to internalize the changes and make long-term commitments. And elicit self-motivational statements that they can do it, even if it's just for the period that you're in treatment. When I work with clients who are involuntary, a lot of them are court-ordered, and I say, okay, I'm not going to pass judgment. I'm not going to tell you what you can and cannot use. However, while you are on probation, I can tell you that you cannot use or there will be this consequence. So do you think you can at least stay clean while you're on papers? Most people say, yeah. So that's a good place to start. I'm not making a judgment. I'm not telling them they have to be clean and sober forever, because forever is a long time. What I'm asking them is, we need to work together to help you get off probation. That's your end goal right now. In order to do that, you can't use. So what can you do, or how confident do you feel that you can stay clean and sober during this 3-month period? In preparation, just like it sounds like, the client's preparing to take action. They've realized they've got a problem, but making change is scary. Regardless of whether you're stopping smoking, you're moving, you're stopping use, whatever, it's scary. Even people who are thinking about if they've got depression or anxiety, those people who are thinking about going to counseling, they think about it for a little while. Versus, I was just having a bad day. Then it's, yeah, I've been kind of down lately, but, it'll blow over. Then they get to the preparation stage where they're identifying that the depression is pretty significant and they may need some help, but they've got to figure out how to work it into their schedule, and they've got to figure out what counselor to use, and there's lots of reasons that they haven't started yet. But that's okay. They're preparing to do it, so we can support them in that preparation. Clarify their goals. You want to find a counselor so you can deal with this. What do you want this counselor to be like? Man, woman? Do you know what style you want? Do you want somebody who actively works with you or somebody who's just going to listen? Offer a menu of options. Let them know the different types of strategies and different types of treatments that are out there. Whether it's mental health or substance abuse or physical health, everything has multiple treatment options. So make sure you're aware of those. And negotiate a contract or a plan. Okay, so you're thinking that you may need treatment and you need to find a therapist, but you're not quite sure yet exactly which therapist you're going to choose. How are you going to do that? And let's set a goal for when you would like to have your first appointment. In action, the client has come in and said, I'm ready. I need to see somebody right now. I'm ready to start doing something about this because I'm sick and tired of being sick and tired. And most of us go, oh, score. These are the clients we love because they come in and they're ready to do something. It's great. Not only because when they're ready, they take action and they get quick results, but I hate to say it, I'll be honest though, they're ready, they take action, get quick results, and we pat our own selves on the back. We're like, yeah, my client's doing better. When it really had only this much to do with us and this much to do with them. But a lot of us internalize it and are very happy for the client and proud of ourselves when they seem to start doing better. We negotiate an action plan, create a treatment plan, whatever you want to call it. You're here, you want to get here. So, what are the steps you need to take? One of the things that an auditor once told me that has stuck forever and ever has been to write treatment plans in terms of knowledge, skills, and abilities. Knowledge is that foundational information they need to know about the issue, about the problem. What causes it in general, what makes it worse, what makes it better, what treatments are available. But also knowledge about themselves. For them, what are their mitigating factors? What are their exacerbating factors? What makes it better? What makes it worse? What are they willing to do? And what does it look like for them when that problem goes away? Because depression may look different for different people. So the client needs to understand what it looks like for them and what it's going to look like when it's gone. So knowledge. Then we move down to skills. Up in knowledge, they've also taken an inventory of all the strengths that they have. So we move down to skills, and we figure out how to strengthen those strengths, and we add a few new tools into the toolbox so they can better deal with those things that are holding them back. Abilities is when they take those skills and tools that they talk about and they use and you practice in group, they use them in the real world, they come back to group, and you process how it worked or how it didn't work and what they could do differently or what they'll do the same the next time. So knowledge, skills, and abilities. This is how you negotiate the action plan. But you also identify, and the negotiation part is, what are we going to work on? Remember when I talked about the client that I worked with who is a criminal justice client, they don't see a problem with their substance abuse a lot of times. They see a problem with being on probation because it's crimping their lifestyle. Okay, so let's go with that. You want to get off probation. In order to do that, you have to successfully complete 10 weeks of treatment and stay clean. That's what the court says. So if you don't have a problem with alcohol and drugs, it shouldn't be a problem at all. But hypothetically, let's just talk about what the next 8 to 10 weeks is going to look like for you and what you might work on, because you're stuck with me, so we might as well do something. If you could go to a counselor or if you could work on any problem in your life, because none of us has a perfect life, what would you work on? Approach it very non-confrontationally that way. Talk to them and identify what they might be willing to work on, because we know that any positive change in any area is probably going to cause positive changes in other areas. Acknowledge any difficulties and support attempts at doing the right thing. If they had difficulty staying clean over the weekend, if they relapsed, if they are feeling worse now than they did 3 days ago. Remember, a relapse isn't just substance abuse. It can also be mental health issues. So they may have difficulty. Let's talk about depression for a second. If they're having a major depressive episode, some days are better than others. Acknowledge that. Normalize it. Support their attempts to continue their goals toward being happier and healthier. Identify risky situations and coping strategies. For substance abuse, going to a bar, being around people that drink, being around old people, places, and things. Risky situations, being in a high-stress situation, risky situation. What are your coping strategies? For mental health, what are some risky situations that may increase your mental health issues that are going on? Depression, anxiety, or mania. Lack of sleep, poor nutrition, stress, being around certain people. There's a lot of different factors, but help the client identify what the risky situations and the triggers are for them. Help the client find new reinforcers. Like I said, there's benefits to use. They used for a reason. They continued to use, even though it was causing them problems, for a reason. What's that reason? And what else could we do to meet that same need? And support perseverance. It's hard to stick to a plan, and sometimes it's not fun. But when they do, especially when it's hard, make sure that you highlight the fact that they had the strength and the courage to do the next right thing. In maintenance, the counselor can support and affirm changes, rehearse new coping strategies, and fine-tune them a little bit. Review goals. Not only does this help them solidify everything, but it also helps clients see how far they've come and what they've done and how remarkable that is. Remind the client about new tools, including making action plans, maintaining an awareness of risky situations, identifying coping strategies for each situation. And on that note, when I talk about triggers and risky situations, I say, okay, it's out there. I have them identify 3 coping strategies or ways to deal with that. Why? Because one doesn't necessarily work all the time. Calling your sponsor. Great thing to try, but if your sponsor doesn't answer, what are you going to do? 3. So you always have a plan A, a plan B, and a plan C. Keep that list with them. Having a relapse prevention plan is great, but if it's in a book somewhere where they can't even find it, doesn't do them any good. When they're in crisis, if they're on the metro on the way home and somebody offers them weed, what do? They start freaking out. They're not thinking as clearly. So if they have that resource with them in a little notebook, folded up, however, great. Or have them use a business card or cut an index card so it fits nicely in their wallet and put the phone numbers of 3 sober social supports they can call if they end up in a situation like that where they're really tempted. Participation in 12-step programs or other sober social support programs. And pursuit of hobbies and cultural activities. Boredom, loneliness, those are 2 big triggers for people. So people need to make sure that they stay involved in their community. And that's going to differ based on your temperament. Some people, like me, I'm an extrovert. I love to be around people. I like to be around a lot of people. That's great. People like my husband, not so much. He would prefer to be around a couple people. So figuring out what's comfortable for you, what it means to be socially involved for the patient. So signs of relapse. Relapse prevention is great. We try to get away from getting to the point where you're at a potential relapse point. But just because you're showing signs of relapse doesn't mean that you've used. The relapse occurs long before the first use occurs again. So let's look at it. Emotional. And a lot of us refer to this as stinking thinking. People are anxious, stressed, irritable, intolerant, lots of anger and defensiveness. Why? Let's think about it. A lot of times, addiction is used to escape from negative feeling states. If your problem is a negative feeling state, then, hey, got a pretty good warning sign that it's coming back if you're having negative feeling states. So, being aware of these things when they linger. We all have anxious moments or a little blip of irritability here and there, but when it starts to predominate, you need to do a self-check. Am I taking care of myself to do everything I can to prevent this? Mood swings, inability to control moods, and isolation. Well, if you're angry, intolerant, irritable, defensive, and having mood swings, not a lot of people are going to want to spend time with you. So, yeah, you may start seeing a lot more isolation because it's too exhausting to try to keep a cap on all of that. And when you can't keep a cap on all of it, people don't want to be around you. Behaviorally, people start isolating and becoming more impulsive. Instead of thinking about the long-term goals, how to get from point A to point B, and that route they're going to take, they want to feel better, so they're going to take whatever detour they can in order to feel better for a little while. Mental signs of relapse include thinking about people, places, and things you used with. In terms of mental health relapse, really dwelling on things that are causing you to feel hopeless, helpless, powerless, or worried. Glamorizing your past use, lying, or hanging out with old using friends. Physical signs of relapse include intense cravings, for alcohol or drugs or something to make you feel better. Use. Potentially physical complaints. If you're having a mental health relapse, you may be somaticizing and start having an upset stomach or tension headaches and backaches. Be aware of all these problems. You may have just pulled a muscle. You may be internalizing stress. You're going to have to keep an eye on what's going on with that patient. Relapse pitfalls. Halt. Hungry, angry, lonely, and tired. Hunger can be physical. That's pretty easy. If we're not getting the appropriate nutrients to make the neurochemicals to help us feel better, probably not going to feel better as quickly. Psychologically tired, just drained. We have those days. You're exhausted, and there's nothing that's really able to do. You need to get some energy back. You need to clear your head. People have different words for it. And being socially hungry, which kind of goes down with loneliness, but just being bored and not feeling like you have anything to do or anything to contribute. Angry. Anger and irritability. Remember, anger protects us. It's fight or flight. Anger or fear. So anger and irritability protects us from something. The question is, what are we protecting ourselves from, and is it worth our energy? Loneliness and an inability to be by yourself is another issue that people have to take a look at. Loneliness is different from being alone. Loneliness is when you can't be alone, because when you're alone in your own head, it's just too scary. Being alone, easy peasy. If you can be alone in your own head and not be afraid. And being tired due to lack of sleep, being irritable, or just being over it. I'm sick and tired of being sick and tired. People need to be aware of this. When you start feeling, for lack of a better clinical term, bleh or icky, you need to check in and see what you can do to correct that before it gets out of hand. So, the purpose of a relapse prevention plan, and the procedure for writing one. The purpose is to assist in reducing unnecessary stress and relapse triggers, and provide prompts for new coping skills. If you think about what barriers or stumbling blocks might be in your path before you get there, then you can plan for them. It's a lot easier. Then you have an arsenal. It's kind of like going backpacking. You wouldn't go backpacking and, hiking and not bring a backpack with at least some water in it, because you know water's not going to be necessarily available. And maybe food. Oh, and maybe a Band-Aid, because you might cut yourself. Oh, and that stingy ointment. See, we think about it for things like hiking. Why don't we think about it for things like life? Think about your journey from depression or addiction to recovery. What bumps might you hit along the way, and what sort of supplies do you need to be prepared? Identify triggers and relapse traps that have got you in the past. So we want to ask clients, you're going along, you're abstinent, or you're feeling good, and then all of a sudden, boom, it hits. Out of the blue. Well, 99% of the time, it doesn't occur out of the blue. So we want to say, all right, let's back up about 6 months and replay it forward in slow motion and see what little things you might have missed that added up to this big kaboom. These are your triggers. These are your relapse warning signs. Devise at least 3 healthy ways of dealing with relapse triggers, but also encourage patients to do inventories and to check in with themselves every day. And we'll talk more about that in a little while. But it's way too easy for life to just kind of pass you by and this stuff to sneak up on you if you're not paying attention. Incorporate a healthy lifestyle into the plan. That means sleep, exercise, I know, heaven forbid, sleep, exercise, good nutrition, and doing things that are fun, enjoyable. Plan for upcoming triggers and traps like holidays, annual work reviews, anything that may be an exceptionally stressful event. And review the relapse prevention plan at least weekly. See what triggers you've encountered, how you've dealt with them, how you could deal with them better, etc. So principles. Principle 1 is stabilization. We need to help people get detoxed. Solve the immediate crises that threaten sobriety or mental health. What immediate crises are really weighing on this person? Help them learn skills to identify and manage post-acute withdrawal and addictive preoccupation. So if they have been using, which we are expecting a co-occurring disorder, they're going to think about those things that used to make the pain go away really fast. It's going to be easy to get preoccupied. Oh, I wish I had a fill in the blank. So how do you identify and manage those thoughts so they don't just continue to play in your head? Establish a daily structure that includes proper diet, exercise, stress management, and regular contact with treatment or support personnel. Not everybody needs to go to treatment. Some people need a little bit more than support recovery groups. But you need to have contact with other people who are involved in your recovery process. Because as humans, we naturally wear blinders. There are some things we just don't want to see, so we just kind of plug our ears and go la, 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 la. Your sober social support is going to call you out on that and say, you know, I've noticed you've been sort of reclusive lately, or I noticed that you've been lying, or whatever the case may be. That person's job is to help you see what's in your blind spots. Principle 2 is integration. We want to take a detailed reconstruction of the presenting problems and the alcohol and drug use history. Why? Because this helps us identify things that have helped you stay sober, and things that have helped you stay happy, and things that have triggered or made worse an addictive episode or a mental health episode. Identify those critical issues that can trigger relapse. Big ones. There's lots of little ones, but there's a few big ones for every person. In reconstructing the recovery and relapse history, identify the recovery tasks that were completed or ignored. How often have you had a client come to you and say, yeah, I got out of treatment, and I did 90 and 90, and I was great, and I was doing fine, and so I started going to a few less meetings, and before I knew it, it had been like a month since I went to a meeting, and next thing I knew, I was drinking again. Well, gee, let's look at the progress of that. Help them look at what they started skipping and why. So my question to that patient wouldn't necessarily be, well, why don't you just go back to meetings? My question would be, why did you stop? Because I didn't feel they were benefiting me anymore. Okay, let's talk about that. One of the things I have my patients who are who have long-term sobriety is I ask them to write down 1 to 3 things that they got out of every meeting. Just keep a little journal somewhere. They don't have to necessarily bring it into me, but that really makes them focus on applying what was in the meeting to their own recovery. Find the sequence of warning signs that lead back to alcohol or drug use or a mental health relapse. Stop going to meetings, start to isolate, start watching more TV, stop exercising and eating right, start sleeping all the time, and next thing you know, you're in a major depressive episode and you can't find anything that you want to do. Follow the chain and see how they got there. That's not how they get there every time, but it gives you a good idea of at least one of the paths to a relapse. Provide relapse education. Remember I said knowledge, skills, and abilities. Learn accurate information about what causes relapse and what can be done to prevent it. This information should include a biopsychosocial model of addictive disease, biological factors that contribute to it, psychological or mental health factors that contribute to it, and social or environmental factors that may contribute to it. Common stuck points in recovery. Complicating factors in relapse. What things might complicate this picture? All of a sudden, an unexpected stressor. Those are generally the complicating factors. Warning sign identification. Have them keep a running list. Relapse warning sign management strategies. Remember I said for every warning sign or every trigger, there should be 3 management strategies. And what is effective recovery planning? We need to educate about what it looks like. Just saying you're going to go to support meetings? No, that's not effective recovery planning. We need to attend to the whole person and their support system and environment. Warning sign identification, self-knowledge. Identify the sequence of problems that's led to alcohol or drug use or mental health issues in the past and how to prevent them in the future. Develop a personal relapse warning sign list. Review the warning signs that you know of and make an initial warning sign list. Analyze those warning signs, because generally you'll see these broad things like holidays. Okay? Is there anything else besides holidays that's a warning sign for you? And it'll trigger other things in their mind, and they're like, oh yeah, well this anniversary and this when I have annual appraisals at work, and have them keep a running list. Make and I call it a pseudo-final warning sign list, because life will continue to evolve and so will this list. But make a final warning sign list and say, okay, these are your warning signs. Go back through the relapse episodes and identify the top 3 or 4 most common warning signs, because most of us have a pretty standard set of behavior that we regress to when we're in the throes of a relapse. Make sure that that person highlights those and keeps their sober social supports apprised. This is something they need to discuss with their supporters, so their supporters can say, you know, you said this is a warning sign when you start spending a whole lot of money really fast, and you've been spending a whole lot of money really fast. I'm wondering if you're okay. Develop individualized warning sign lists by identifying irrational thoughts, unmanageable feelings, and self-defeating behaviors. This is a big CBT thing, so we're going to go into it a little bit. There are 2 different types of warning signs that you want to look at. Those related to core psychological issues, problems from childhood stemming from self-esteem, attachment, all that stuff. And those related to core addictive issues or problems that generated or emanated from the addiction itself. When patterns of addictive thinking that justify relapse are reactivated, a relapse occurs. Justification, minimization, rationalization, denial, all of those things, as soon as those are up there, we've got a problem. So let's talk about some of those irrational thoughts. Certain acts are awful or wicked and must be punished. True. People do some pretty horrendous things. Is it worth my energy to get all tied up in it about something somebody did to somebody else that doesn't affect me? The judgment call each person has to make in each situation. Sometimes the answer is yes. Sometimes the answer is there's either nothing I can do about it, it's one of those things I cannot change, or I don't have the energy right now. If I give energy to that, then I'm going to start down that relapse path. It's horrible when things are not the way we like them to be. Well, yeah, but life's not fair. So, okay, there are some times where we just got to suck it up. When something doesn't go your way, how do you deal with it? Instead of focusing on how bad it is, because you can't change it, what are you going to do about it? And see how we're having a cognitive shift. Human misery is invariably externally caused and is forced on us by outside people and events. No. Really crappy things happen, that's true. However, it's up to you how you interpret it and what you do with it. You can let it control you forever. You can let it affect you for a period of time, or you can let it roll on by. You have to decide how much of your energy it's worth. How much power are you going to give those other people? If something is or may be dangerous or fearsome, we should be terribly upset and endlessly obsess about it. I don't have the time to endlessly obsess about anything. I can't even say it. If something is dangerous or fearsome, we need to figure out what to do about it. Worry is energy tied up in the future. Regret is energy tied up in the past. So let's not tie up that energy. Let's stay in the present and deal with it. It's easier to avoid than face life's difficulties and responsibilities. In the short term, yeah, it is. Short term is easier to pull the covers over your head and go back to sleep. But in a week or a month or a year, eventually all that stuff catches up with you and it's way harder to fix once it's out of control. We absolutely need something other or stronger or greater than ourselves. I'm not going to go into this one too much because there's a lot of controversy. But we don't need it for everything. We can make decisions. We can make choices. Some people believe there's a higher power. That's great. Some people believe there's not. That's fine too. But you've got to figure out what part of your life you have control of. We should be thoroughly competent in all possible respects. It ain't going to happen. You can be kind of good at almost everything, or really good at a few things, and sort of good at other things. You've got to choose. You only have a certain amount of energy. Nobody is thoroughly competent in all possible respects. Because something once strongly affected our life, it should indefinitely affect it. How long are you going to give that event or that person your energy and your power? That's what I ask my clients. It strongly affected your life. Okay, what did you learn from it? How did it change you? How's it affecting you now? Then we look at, it's affecting you this way right now. Are you good with that? If not, what can we do about it? Nothing has to affect us indefinitely. We must have certain and perfect control over things. Perfect, there's no such thing. It's nice to have control. Most of us really love control, but we don't have control over everything. So at a certain point, we need to accept those things we cannot change. And that's the step one honesty component that so many people miss. They want to change everybody else and everything else. It doesn't happen. You need to learn how to roll with the punches instead of just expecting no punches are going to be thrown. Human happiness can be achieved by inertia and inaction. Well, inertia and inaction are definitely choices. I can't imagine that being a very happy life. And that, like we talked about earlier, as life's difficulties and challenges come to you, if you don't deal with them then, they're only going to fester and be a lot harder to deal with later. We have virtually no control over our emotions, and we cannot help feeling disturbed. We have primitive fight or flight reactions. That's true. We have no control over that instantaneous reaction. What we do with it, we do have control over. Taking anger and nurturing it into a grudge and really giving it a lot of your time and energy is a choice. Now, sometimes it's a choice worth making, and each person has to decide that for themselves. Is this a fight worth fighting? And if it's a fight worth fighting, do I want to use my energy for the fight or to get really angry about it? You don't have to continue to nurture negative feelings. You can choose to let it go or do something about it. Cognitive distortions is another big sticking point. A lot of people with addictions and mental health issues tend to minimize their successes. Well, anybody could have done that. No, not necessarily. And they exaggerate their failures. So they focus on the negative and ignore the positive. Think about how that makes you feel after a while. Polarization, all or nothing thinking. I'm either perfect at everything or I'm a complete failure. Again, think about approaching life that way. How would you feel on a day-to-day basis? It would be exhausting and stressful and demeaning most of the time. Personalization, this is a big one. Helping clients realize that they're really not the center of everybody else's universe. So if somebody says or does something and it's rude or insensitive, it wasn't necessarily meant to be rude or insensitive. Sometimes it was. There are rude, insensitive people. But taking everything personally, assuming that every time somebody that walks by you is in a bad mood, it's your fault, how exhausting is that? Get over yourself. Accept that people have bad moods, and it may not be caused by you. Accept that people may say something rude and insensitive, and they didn't really mean it to be rude and insensitive. My son's at that age right now where, as we say around our house, he has no filter. And he will say things that I'm just like, wow, I don't even believe that came out of your mouth. And I know he wasn't trying to be hurtful, but sometimes he just says those things, and I'm like, really, son? He's like, oh, that wasn't nice, was it? I'm like, no. He's like, I didn't mean it that way. So helping our clients understand that people aren't on guard all the time, and they're also not always on guard about, I need to make sure I say everything perfectly so I don't offend or upset her. People don't want to walk on eggshells around you all the time. So take what you think is there. If you think it was rude and insensitive, deal with it or not. You've got to choose what to do with it, but taking it personally and nurturing it is just going to drag you down. Biased recall. When we're in a bad mood, a lot of times we focus on the bad things and the negativity. So then we think back and we're like, oh, this whole week has sucked. Because you're focusing on those things that were prevalent in your mind. You were in a bad mood, which caused you to focus on the negative things, and it's just this vicious cycle. So biased recall is when people tend to focus on the negative and then perceive everything as being more negative. The nice thing is you can turn it around and be biased in a positive way. Entitlement. Well, I should have been able to get that, which also goes in with shoulds and musts. You know, life's not fair. So this whole entitlement thing, you need to kind of weigh. And yes, we should be treated with respect. We should be seen on time when we go to the doctor's office. We should be able to get in and out of the grocery store and not have to wait in a line that's 20 miles long. It doesn't always happen that way, and people aren't going, well, Dr. Snipes is coming today, so I guess we better have extra cashiers on. It doesn't happen that way. I'm really not that important in people's lives. So getting over that sense of entitlement and personal affront when everything doesn't go exactly as you expect. And shoulds and musts. Yoda has this saying, do or do not, there is no try. Well, shoulds and musts. You should do something. I don't care if you should or not. Are you going to do it or are you not? Must. Most things we don't have to do. You choose to. Replacing those simple words in your vocabulary is very liberating. Just try it for a day. Must and need to. I need to go to the grocery store. Yeah, well, there's a lot of things I need to do. What am I going to choose to do? Principle 5, coping skills. Learn how to manage or cope with warning signs as they occur. Again, patients have strengths. They've been using strengths long before they saw you for their brief periods of happiness or sobriety. Latch on to those strengths and intensify them. And then add some more coping skills as they're needed. On a behavioral level, people need to learn how to avoid situations that trigger warning signs. You know, don't put yourself in the middle of a hornet's nest if you don't want to get stung by a hornet. And then modify behavioral responses when needed. If you're riding your bike along and you happen to run into a hornet's nest, you still don't want to get stung, so what do? Cognitive and affective, so how you think and how you feel. Challenge irrational thoughts and deal with unmanageable feelings when triggered. So first, challenge these tapes in your head that tell you you must do this. You have to be loved all the time. You have to be perfect. Who says? The other thing that I tell my patients is, all right, these tapes, these things you're hearing in your head, these things you're telling yourself, which probably came from somewhere else, would you tell that to your child? Well, you have to be perfect all the time or I'm not going to love you. No. So why are you holding yourself to an unreasonable standard? If it's not good enough for your child, it's not good enough for you. So let's not be unreasonable. And then dealing with unmanageable or unpleasant feelings when triggered. When you feel excruciating anger or despair, what do? It happens. You can't avoid it all the time. So what do? We need to have some plans here in place because when we're feeling agonizing depression or anger, we're not thinking real clearly. We're in crisis. So we need to have a plan in place. And managing the core issues, identifying the core psychological and addictive issues that initially create the warning signs. And a lot of those go back to those tapes about what you believe you should do and your concept of what you need to be. And all of those are irrational thoughts and cognitive distortions. But dealing with those and finding a place where you can accept yourself and life on life's terms. Principle 6, change. Recovery planning is a schedule of recovery activities that will help patients recognize and manage warning signs as they develop. It's important to review each warning sign on your final warning sign list and ensure that there's a scheduled recovery activity, or 3, for each. Make sure they have an array of activities. Talked about inventories earlier. Principle 7 is awareness. Think about today. You got up, you got out of bed, you got dressed, you went to work. Did you stop and think, how am I feeling emotionally? How am I thinking? Am I clear-headed? How do I feel physically? A little achy here. No, we don't have time for that. Well, we do, but we don't make the time for it. Daily inventories help people monitor compliance with their recovery program or their health and wellness program. It doesn't have to just be recovery. And check for the emergence of relapse warning signs. A morning inventory can be used to plan the day. An evening inventory reviews progress and problems that occurred during the day. I usually have patients start doing both. Morning takes 10 minutes, evening takes 10 minutes. It's not a big deal. It doesn't necessarily have to be written down. I suggested it first. But, you know, for some people, they do their morning inventory while they're drinking their coffee, and they do their evening inventory while they're standing in the shower trying to let the stress of the day rinse down the drain. That's fine. The fact is they're checking in with themselves. A typical morning inventory asks the patient to identify 3 primary goals for that day, create a to-do list, and schedule time for completion of each task. It doesn't have to be super detailed. One of the goals can be to stay clean and sober. Another one of the goals can be to get through the day without screaming at somebody. And a third goal can be to get to all your meetings on time. I mean, it doesn't have to be anything earth-shattering. Put those goals on your to-do list and figure out how you're going to get those things done. In the evening, you review those goals in that list, determine whether everything was completed, if there were any relapse warning signs. If you did do it, great. Keep up the good work. If you didn't do it, what got in your way and what could you do differently next time? Also in awareness is the decisional balance exercise. Looking at the benefits and the drawbacks to whatever the present behavior is, depression, substance use, and looking at the benefits and the drawbacks of recovery or a different way. There are benefits and drawbacks to both. And again, we need to acknowledge all aspects of the change process in order to make sure that we're making these new behaviors as rewarding and motivating as possible. Principle 8, significant others. Individuals cannot recover alone. Family members, 12-step program sponsors, counselors, sober peers, whomever you can get in your sober support system, score. You need people. As humans, one of the best buffers against stress is sane, sober social supports. The more psychologically and emotionally healthy the significant others are, the more likely they are to be helpful. One of the things we do in family education group is we teach the significant others the same coping skills and basically the same curriculum that we're teaching the identified patient. However, we tell them, you know, when your loved one starts feeling stress or seeming depressed, let's identify some things that they could do. And oftentimes they spout out some things, and then we say, all right, well, one of the best ways you can help them is by also modeling that behavior. So if you started to feel stressed, what does that look like for you, and what can you do to de-escalate your stress? Help them apply it, help them see how modeling this for the identified patient is going to help the identified patient. We're not saying they're sick. We're helping them help their significant other. The more directly the significant others are involved in the relapse prevention planning process, the more likely they are to become engaged in supporting positive efforts and intervening when necessary. Get the significant others involved. If they don't know what they're looking for, they can't point it out. If they're just handed a list and you don't talk about how this discussion is going to happen, it generally ends up going poorly. So it's good to get the support people and the identified patient in the same room and say, okay, support person, when you start seeing a warning sign, how are you going to approach identified patient? And obviously we use their names, not titles like that. But how are you going to approach identified patient to let them know that you've noticed a warning sign? They'll say something. The identified patient will usually grumble, say, oh, yeah. And then we go back to the identified patient and we say, okay, now is there a chance that that could cause you to start feeling defensive? Most of the time the answer is yes. How are we going to deal with that? Have that discussion at the front end of treatment. That way we can have an open dialogue. And sometimes a duck is a duck. And the significant other will say, you've been doing this, I'm wondering if you're relapsing. The person will say, no, I just wanted to spend the evening on the internet. Okay, a duck is a duck. But the significant other was able to point it out. It's also a time when you can start talking about identifying communication and relationship issues, so there's not as much blaming. Well, she makes me drink. When she does this, she makes me drink. Well, no, not really. You choose to drink because you're feeling angry. So let's talk about that. That's usually month 2 or month 3 that you start talking about relationship issues. But opening that dialogue is really important, and keeping the significant others engaged. Maintenance. You want to update your relapse prevention plan on a monthly basis for the first 3 months, because it's amazing the things that you'll miss when you do your initial one. Quarterly for the remainder of the first year. Again, you're still dealing with life as it comes at you and going, oh, I forgot to put something in there on how to deal with this. Twice a year for the next 2 years, and annually thereafter. Yep, I said thereafter. So if you've got 20 years of sobriety, annually you're still going over that relapse prevention plan and going, yep, I'm eating right, I'm exercising, I'm doing this, I'm doing that. Nearly 2/3 of all relapses occur during the first 6 months of recovery. It's important to let our clients know this so they can be ever vigilant. Less than 1/4 of the variables that actually cause relapse can be predicted during the initial treatment phase. So, they're in the initial treatment phase, they do their relapse warning signs and relapse prevention plan. Less than 1/4 of their triggers are going to be on that list, which is why they need to update it so much initially. A relapse prevention plan update session involves a review of the original assessment, warning sign list, management strategies, and recovery plan. Let's see what we're already working with. An update of the assessment with progress or problems since the previous date. What's changed? What do we need to change? Incorporation of the new warning signs and management strategies for them. So we've identified the changes, we've identified some new stumbling blocks, and we've identified a bunch of new management strategies. Now, you can use the same management strategy for multiple triggers, but again, for each trigger or warning sign, you need to have 3 options. An elimination of activities that are no longer needed. Some people are only on a short course of medicine. Some people choose to back off of support meetings every day. You can talk about what those different things need to look like. Maybe elimination of outpatient counseling. At a certain point, we've got to let people try to fly. So, but we don't push them out of the nest. Step down is crucial. Gradual movement from a more intensive level of care helps prevent people's new coping skills from being overwhelmed. Think of when you went from high school to college. Rigorous structure, curfews, to free-for-all. That's why a lot of freshmen flunk out. Residential treatment to meetings. Meetings are good, but it's kind of the same comparison. So helping people step down their level of structure gradually from residential to 5-day-a-week IOP to 4 to 3 to aftercare, and it can go pretty quickly, but it's important to gradually step them down, since we know from the last slide that they've already only identified 25% or less of their relapse warning signs and triggers. So as they go back out in the world, things will start hitting them. They'll have to adjust that relapse prevention plan pretty rapidly at first, and then as that adjustment slows down, then they can gradually decrease the intensity of their treatment. Intensive outpatient provides a place to receive support, hope, and encouragement on a daily basis. Outpatient is appropriate once the patient has reliable, healthy support network outside of therapy. In summary, we want to look at the past to identify reasons for past use. because the best predictor of the future is what you did in the past, unless you start making conscious choices to change. People need to plan for future stressors and bumps in the road. And it's important that we assist the patient in developing sober social support systems. Help them make those first contacts. Help them figure out how to go to meetings. Some clinicians will go to the first meeting with the patient. Some don't think it's appropriate. That's your call. But help your patient figure out where they're going to find these people and how they're going to integrate. So again, relapse prevention starts the minute you do that assessment. Before that client walks out of your office, you want to have a plan of how are you going to stay sober or deal with your depression between now and the next time you see me, which may be tomorrow, it may be next week. Let's develop a short-term plan. You can talk about triggers. You can even have them, that can be a homework assignment, to work on listing triggers and things that they could do to deal with those triggers, and talk about that in your first session. That empowers the client to start looking at these things and saying, oh, I guess it didn't come from out of the blue, and start making conscious choices to change. And that is relapse prevention. Thank you for joining us today, and have a wonderful rest of your day.